This is NDTV, and you're watching NDTV 24/7.
Hello and welcome to our show, Health and Wellness, Myths versus Facts. I'm Gargi Rawat. Endocrine glands produce and secrete hormones that are responsible for many important body functions. It plays a vital role in whether or not you develop diabetes, thyroid disease, growth disorders, sexual dysfunction, as well as a host of other hormone-related disorders. How often do you consider the health of your adrenals when you consider the state of your health? Now, the sad fact is that the adrenal health is largely overlooked. The role of the adrenal glands in your body is to release certain hormones directly into the bloodstream. Many of these hormones have to do with how the body responds to stress, and some are vital to existence. Adrenal health may not be at the top of your priority list when it comes to looking at your body, but if you do not take care of your adrenal glands, you may suffer from various conditions associated with it. And we have an expert panel with us. Our experts will provide medically accurate and actionable advice to help prevent the development of adrenal disorders, as well as guide our viewers with effective long-term management strategies. We're joined by Dr. Kaushik Biswas, Senior Consultant, Department of Endocrinology, Medica Super Speciality Hospital, Kolkata; Dr. Sunil Mishra, Director, Endocrinology and Diabetology, Medanta, the Medicity, Gurugram; and Dr. Aditi Chopra, Consultant Endocrinologist, Fortis Hospital, Bengaluru. Right, Dr. Mishra, if I can ask you that question. Unbalanced hormones can cause drastic changes in our bodies, and what happens when the adrenal gland loses this balance?
Okay. So, you see, the adrenal gland is an important organ in the body which secrete hormone, and primarily it has two parts, the adrenal cortex and adrenal medulla. The outer part is cortex, which secrete three major hormones. One of them is the cortisol, other is the aldosterone, and third is the adrenal steroid hormone for gonads, control the testosterone and the other things. The internal part of the adrenal gland is the adrenal medulla, which secrete the adrenaline and noradrenaline hormone. These hormones are important for the control of the metabolism of the body, and mainly regulate the blood pressure, regulate the electrolyte balance of the body, and also help us in overcoming the stressful situation. So as you were asking about what happens when the gland is not functioning, so that means the gland is underactive because of the various reasons. So deficiency of these hormones will result into the low blood pressure, electrolyte imbalance, mainly the low sodium. People appetite will go down. They will lose undue weight without any effort. Pigmentation may change. The body pigmentation may become darker. And a right timely diagnosis of the adrenal gland insufficiency may result into the correction and living a normal life of the individual. So therefore, the level of suspicion should be high. People having such symptoms when any other reason is not apparent should definitely take into consideration of the adrenal gland insufficiency or underactive adrenal gland.
All right, Dr. Chopra, aldosterone is one more hormone secreted by the adrenal gland. And what are some of the symptoms that can help alert a person that his or her body is producing excessive aldosterone?
Right. So aldosterone is another essential hormone which is secreted from the adrenal cortex. And it is a hormone which maintains the sodium and the potassium balance of the body. And it hence regulates the blood pressure. So what happens when there is excess aldosterone in the body? Whenever there is excess aldosterone in the body, there will be more of sodium retention in the body by the kidneys, and there will be loss of potassium by the kidneys. So because of this excessive retention of sodium, there can be high blood pressure. So that is the most common presentation of high aldosterone secretion, that is high blood pressure. So the symptoms are usually of high blood pressure like headache, giddiness, blurred vision. And blood pressure, because of hyperaldosteronism, is usually resistant hypertension, that is difficult to treat. So most of the patients, especially young patients less than 30, what we see is they require 3 or more drugs to control their blood pressure, that is when you should have a suspicion of high aldosterone secretion in your body. In addition to sodium retention, there is also loss of potassium by the kidneys, and it leads to a condition which is known as hypokalemia, that is low potassium in the blood. This leads to muscle weakness, muscle cramps, increased urinary frequency, and also it can lead to heart rhythm abnormalities. And if the potassium levels in the blood is really low, it can also cause paralysis of the arms and the legs. So predominantly symptoms of high blood pressure and in some patients symptoms of low potassium is what we expect when the aldosterone levels in the blood are high.
All right, Dr. Kaushik, Dr. Biswas there with us. And if you could tell us, adrenaline is the major hormone secreted by the adrenaline gland. And what happens when there's excess adrenaline in your body?
Okay, adrenal gland produces both adrenaline and noradrenaline. We also call it norepinephrine and epinephrine. Adrenaline is a hormone which is associated with a vascular phenomenon, like it causes vasoconstrictions, it increases the heart rate. So heart rate will be elevated, there will be increased blood pressure, and they are associated with the so-called sympathoadrenal response. So when there is excess of this kind of hormones, there could be elevation of blood pressure, there could be elevations of heart rates, and sometimes paradoxically there could be orthostatic hypotension because of the excessive stimulation of the peripheral, downregulation of the peripheral receptors for those hormones. Now there are several conditions physiologically, even during any physiological stress. Normally adrenal gland secretes adrenaline or noradrenalines, but there are some pathological conditions like pheochromocytoma, which is a tumor of chromaffin cell origin, which may secrete both adrenaline or noradrenaline, and even some cases of other catecholamines, which can lead to blood pressure elevations, which may be paroxysmal or episodic, and the presentation could be catastrophic one, and there could be very high rise of blood pressure all on a sudden. However, in most of the cases, we see sustained hypertension in case of pheochromocytoma. If I find adrenal mass during any surgery because of unrelated cause, if somebody is undergoing ultrasonography for any other reasons, and if we find a gland, a tumor which is suggestive of pheochromocytoma, it needs to be confirmed by the biochemical test as well as by imaging modalities like CT scan or in some cases MRI, so that before doing any surgery, we need to rule out the pheochromocytoma, otherwise catastrophic crisis related to severe adrenal release may occur.
All right, let's talk now about Conn's syndrome. And Dr. Mishra, who's more likely to get affected by Conn's syndrome? Are there specific risk factors to get this condition that people should be aware of?
Right. So first thing is that we need to understand what's the Conn syndrome. Conn syndrome is a condition when there is excess unregulated production of the aldosterone hormone in the body. This aldosterone production will result into the sodium retention and the loss of the potassium and high blood pressure. And this blood pressure control may be very difficult to achieve. People require multiple antihypertensive drugs to control this blood pressure. And it may be associated with other problems like low potassium, muscle paralysis, and also end organ damage like in the kidneys and in the heart. There are no specific risk factor for the Conn syndrome. So we can't tell that which person is going to develop the Conn syndrome or which person is not going to develop the Conn syndrome. Usual age of presentation is between 30 to 40 years of the age. The most important thing about the Conn syndrome is that untimely occurrence of the blood pressure, like below age of 30 or above 50 and 60, the blood pressure happening for first time, blood pressure is associated with the low potassium or occurrence of the low potassium during the treatment of the blood pressure, we need to suspect the Conn syndrome. Similarly, if people requiring multiple antihypertensive drug, multiple BP medications, it's not the number of the pill, but the content into the pill is more important. So you need to ask your doctor, am I getting more than usual amount of the BP medication to control my blood pressure? If there is any reason for that, and if there is any treatable reason for blood pressure control. Because Conn syndrome and the pheochromocytoma, Mr. Kaushik was talking about, are the curable region of the hypertension. And the pickup rate is only when we have to level a high level of the suspicion. So we have to suspect those conditions more often, then only we can diagnose the condition better. There is no, as we know, there is no specific risk factor to reduce the development of the Conn syndrome because we don't know. It's a genetic abnormality, and that resulting into the unregulated production of the hormone aldosterone from the adrenal gland. The best way to detect the condition early is to have the level of the suspicion for the condition, as I enumerated, and then treat it accordingly. Many a time surgery might be required, and some time also equally we may treat it by medical management also. Thank you.
All right, and staying with Conn's syndrome, Dr. Chopra, which medical conditions may be linked to Conn syndrome?
Right. So as we discussed, that Conn syndrome is associated with high blood pressure, and it has an effect on the blood vessels also. So it increases your risk for heart attacks, heart failures. It can also affect the blood vessels of the brain, leading to strokes, which in turn can cause paralysis. And it also can affect the kidneys, leading to kidney failure. And if the potassium levels are really low, it can have an effect on the rhythm of the heart. So it can be associated with rhythm abnormalities of the heart. And also because of low potassium, there can be paralysis, which we call as hypokalemic paralysis. So these are the common things, are the complications that we have with Conn syndrome, increasing risk for heart attacks, heart failure, strokes, and kidney problems.
All right, Dr. Biswas, staying with Conn syndrome, how common is this syndrome in Indians? Is it different with respect to male and female patients?
Okay, there is a lack of data in Indian perspective, but however, worldwide data is showing that in patients with hypertension or those patients having hypertension, around 5 to 14% of patients might be having Conn syndrome. And one study has been published from India comprising patients having both diabetes and as well as hypertension. And it was found that 4% of the study population were having Conn syndrome. So especially we should, as previously been mentioned, when I am dealing with the patients with hypertension, if the age is below 30, if the hypertension is drug resistance, requiring more than 3 or 4 drugs, if it is severe hypertension, it is associated with hypokalemia. So we should always consider a secondary cause of hypertension, and Conn syndrome is one of the most common causes of secondary hypertension. There has been a female preponderance of Conn syndrome. It has been shown in one study that it can be found as high as 2-fold in female in comparison to male patients. Thank you.
All right. Well, thank you so much, doctors. And we'll just slip into a short break right now and return with more questions for you. Do stay with us. Welcome back. You're watching Health and Wellness, Myths versus Facts, and we're talking about hormones and their importance to our health. Let's go across to our doctors. Dr. Biswas, what is the relationship between a primary aldosteronism and secondary hypertension?
Yeah, as I was talking about, the primary aldosteronism is the most common cause of secondary hypertension, and the entity has to be identified because there's a chance of very good chance of treatment, permanent treatment of that conditions, and near about 50% of cases might be patients might be having permanent control of their blood pressure, after removal of aldosterone secreting tumors, or at least there could be significant reduction of antihypertensive medications in that patient after removal of aldosterone secreting tumor. Not only that, as some of the panelists had already said, that aldosterone itself has a direct effect on myocardium and vasculature, so that the direct effect will also be alleviated. So identifying primary aldosteronism in patients with secondary hypertension is very important, not only to control hypertension but to alleviate, but to possibly provide a permanent cure for the conditions and to avoid the other ill effects or bad effects of aldosterone in our body. Thank you.
Now, Dr. Mishra, to talk more about aldosteronism, what are the screening tests for primary aldosteronism?
Right. So, there are screening tests for primary aldosteronism. The first and foremost thing about the diagnosis of this condition or the pickup of the condition is that high level of the suspicion. So we and other panelists have already spoke about what are the conditions where we have to screen for primary aldosteronism. And some of the data from the West also says that it may contribute to around 15 to 25% of the hypertension. And as Dr. Kaushik was rightly saying, this is the most common cause of the secondary hypertension, which can be curable or treated well with the specific medications. So there are three levels of the steps for the appropriate diagnosis: the screening test, the confirmatory test, and then finally localizing the condition. The screening test now readily available in commercial lab, which were earlier available only a selective and research lab only. So first and foremost thing for that is aldosterone to renin ratio. A blood sample is taken from the people and from the person with hypertension where we suspect the primary aldosteronism. The simple blood test in the morning, it should be done before 10 a.m. Person should be awake at least for 2 hours, upright for 1 hour, and 15 minutes sitting at the sampling chair before we draw the sample. Before we do the sampling, the aldosterone ratio, we have to ensure that the person is not on the medication, blood pressure medication, which may alter this ratio. So your doctor will tell you that which medication to be stopped appropriately before what time you do the test. The third thing is that the potassium level should be normalized before we undertake this screening test for blood. It should not be done in the person with a low potassium level. At least it should be above 4 before we conduct the test. And sampling time I've already enumerated. It should be fasting, 2 hour awakening, 1 hour upright, 15 minutes sitting in the sampling chair. Thank you.
All right, Dr. Chopra, now returning to Conn syndrome that we were discussing before the break. Can Conn syndrome be cured, and are the medications to be taken lifelong, and can Conn syndrome be fatal if ignored?
Right. So coming to one of the most important part, that is the treatment. So treatment for Conn syndrome depends on the reason why you have Conn syndrome. So if it is because of a adrenal adenoma, which is a benign tumor found in the adrenal gland, then the treatment for that is surgery, and after which it can lead to cure. It can also be because of overfunctioning of both the adrenal glands, that is known as bilateral adrenal hyperplasia. In that case, the treatment is usually medical management, where we give drugs, and the drugs are known as mineralocorticoid receptor antagonist. These drugs, they block the effect of aldosterone in the body, and they cause a decline in blood pressure and normalization of the potassium. If it is because of the second condition, that is bilateral adrenal hyperplasia, then the medical management needs to be continued lifelong. So the point to emphasize here is that Conn syndrome has an excellent prognosis if it is diagnosed early and treated adequately. But the problem usually is a delay in diagnosis and hence a delay in treatment. And because of that, the complications of Conns, like we see heart attack, kidney problems, strokes, all those set in. And then the fatality because of Conn syndrome is higher than what we see in general hypertension. So it is important to diagnose and treat early. and the treatment usually leads to a very good prognosis. Thank you.
Right now, Dr. Biswas, why is there hypokalemia in Conn syndrome?
Yeah, this is the aldosterone actually acts on the distal convoluted tubule of the kidney, and it upregulates a channel known as epithelial sodium channel, and it actually reclaims, it absorbs the sodium from the urine, and that's why and the sodium is entered into the blood again, and while during that process there is also excretion of potassium into the urine, and sometimes it is also associated with hydrogen ion excretion. So what occurs in hyperaldosteronism, because of aldosterone's action, there is increased sodium and water reabsorption in the kidney, in the distal convoluted tubule of the nephrons, and as well as there is loss of potassium through urine. So that is the reason why there is hypertension, and that is the reason why there is hypokalemia.
All right, Dr. Mishra, how does primary aldosteronism affect glucose tolerance?
So this is interesting thing, how a tiny adrenal gland secreting one hormone, aldosterone, causing high blood pressure and then causing glucose intolerance or disbalance of the glucose level. So people with primary aldosteronism at a higher risk of developing high blood glucose, that may range from a pre-diabetes condition to the overt diabetes. This is primarily related to what Dr. Kaushik was speaking about, the potassium. A low potassium level is definitely regarded and required for the secretion of the insulin from the beta cells, those cells which are designated to secrete the insulin from the pancreas. An imbalance in the potassium level, and especially the low potassium level, may result into decreased secretion of the insulin and resulting into the glucose intolerance. This has been reported in various studies in the primary aldosteronism, hyperaldosteronism, and Conn syndrome, that people up to 15, 20, or 25% might have some sort of the glucose intolerance up to the level of the diabetes. And whenever we treat the condition, if it is only related to hypokalemia and Conn syndrome, once we treat the condition either by the medical mean or by the surgical mean, the glucose intolerance will revert back to the normal glucose status and person will become a non-diabetic again. So therefore, not only the hypertension, not only the cardiac disease, not only the kidney and the vascular disease, the glucose intolerance is also a part of the Conn syndrome, and people should be aware about this condition. Thank you.
All right. Well, thank you so much, doctors, for joining us and talking about hormones and health. And hopefully that's helped a lot of our viewers. Thank you all for watching at home. Goodbye.